Yeah, okay. I might just start, and hopefully people will join us while I'm doing the introductions. Just like to welcome everybody to today's webinar, being presented by the Health Services Research Association of Australia and New Zealand. I'm the Executive Officer, Sarah Green. The association is set up to promote education, training and networking and build capacity for health services researchers. We run these webinars, try and run them once a month. We're always keen to hear from participants of any topics and speakers you'd like to hear about for future webinars, so do drop me a line if you've got any suggestions. A lot of other activities and events happening, so I just encourage delegates to take a look at our website and look at our membership options. A couple of housekeeping issues this morning. We can't see or hear you, but you're able to communicate with us using the chat button that you'll find at the bottom of your screen if you move your mouse around. And you can ask questions using the Q&A button. We're expecting the presentation this morning to take about 40 minutes, and then there'll be about 10-15 minutes for questions at the end. And what we will do is read those questions out to the presenters and hopefully get a good discussion going. I am recording this morning's webinar and should have it on the HSR website early next week, and you'll get a follow-up email with the link how to access that. And I'm sorry, this morning we were hoping that we had somebody from our executive committee who was going to chair the session, but they're having problems with their microphone. So I will try and do my best. So I'd really be pleased to welcome Jean-Frédéric Levesque and Kim Sutherland. Jean-Frédéric is the Chief Executive Officer of the New South Wales Agency for Clinical Innovation. And prior to that, from 2013, he was the Chief Executive of the Bureau of Health Information. And Dr. Levesque has held senior positions responsible for publicly reporting information about the Canadian health system. And Kim is the acting Chief Executive of the Bureau of Health Information. She is a health services researcher with experience in performance measurement and reporting, evaluation and assessment of quality change management in healthcare organisations, and the diffusion of innovations. I understand that the two of them are going to do a bit of a tag team this morning through the presentation, and then we'll handle the Q&A session together as well. Thank you.
Excellent. Thank you very much, Sarah. It's a pleasure for us to be here today and be able to talk about that recent paper that we published in the British Medical Journal Open Edition. It's really the culmination of a few years of work looking at different literature around performance information, but also having to act and perform in that space of reporting on performance. And really, we came to the realization that there was a need for a bit more of an integrated framework about how to understand how can performance information make a difference for healthcare systems. So I'm Jean-Frédéric Levesque, as previously mentioned. I'll be sharing the session with Kim.
Good morning, I'm Kim Sutherland.
So the presentation is called "What Role Does Performance Information Play in Securing Improvement in Healthcare?" And it is a conceptual framework that focuses on levers for change, but really from the angle of providing performance information to change healthcare. So across healthcare systems, there is really a consensus around the need for independent and impartial assessment of performance. Many healthcare systems around the world have come to that realization. Many organizations have been established so that there's a bit of an arm's length between delivering care, planning, organizing care, and designing policies, and evaluating those and reporting for the purpose of accountability and for the purpose of informing the population. So there's no question, in many modern healthcare systems, this is now well established. And the goal really is to make sure that we can go from data, which is really the codification of reality. You know, we capture what's happening in healthcare systems. We put them in data sets, in files that we can interrogate, and that becomes data that we can then analyze. We wanted to create information, of course, and that's why we've got many indicators, many measures. Ultimately, it has to generate knowledge of different stakeholders, different actors. You know, we're talking about clinicians, we're talking about managers, policymakers. If this information somehow doesn't get to their cognition, obviously, healthcare or performance information is not going to make a difference. But we also know that knowledge is not sufficient. We need action, and we need different interventions to be implemented in healthcare system for ultimately for change to happen. So how do we go through this cycle of data, information, knowledge, action, and change is really the question that was at the core of the work that we did in this academic endeavor. Because in reality, there's less agreement about how the measurement and reporting of performance actually improves healthcare. Some people emphasize patient's choice, for example, as being really the way that it works. Some people talk about blaming or a blaming culture to really make clinicians change their practice, for example. Others say that, no, this is all about the programs that we can put in place to hold clinicians and managers' hands in the tough work that is quality improvement. And a lot of different opinions basically are around. So today we'll briefly talk about the aims and methods. We'll review the foundations that were really the building blocks for the model that we're presenting in the third section, this integrated model around the levers. And then we'll have a brief discussion about some of the strengths, some of the weaknesses of our work, but also where we think that it's contributing to a better approach to performance measurement reporting using different levers. So as I mentioned, this paper was published recently. It is in the British Medical Journal Open and shares exactly the same title as the title of this presentation. And really the aim of this paper can be found in the conclusion of the paper. And this is really just an excerpt from the paper. So we do feel that this paper provides a clear framework to support better planning and evaluation of efforts to measure and publicly report performance in the healthcare sector. And it really starts with the premise that availability of information is not sufficient to generate change. And we need to understand how information works with other types of activities to really leverage change. And that's what we aim to achieve in this paper. So in terms of methods, we did a scanning of the academic and grey literature. We first started with a review of seminal work, important papers, important reports that we all knew about, or that we both knew about, having worked for many years in the space of performance measurement and reporting. So, you know, for example, the work of the Institute of Medicine in the US was quite important as a starting point. The work around institutionalization theory, you know, we had some very key papers to start from that had really changed the field of healthcare, of health services research one way or the other to start this academic and grey literature. Then we did a snowballing process to ensure that we would review the more recent papers, ensuring that we would capture the different work that they had cited, but also from an institutional perspective, we did go to the most important institutions active in the space of performance measurement and reporting, or health systems, you know, assessment in general, and try to grab really important work out of their websites and out of their recent reports. And we complemented that with a search of reference databases as well. But this is not a systematic review. We really, because of the nature of the question, we had to go through that different approach to the literature review. So the selection criteria really were that the work that we would find needed to have outlined a conceptual framework around how information can generate change in the healthcare system, how would describe the different types of approaches used to secure improvement through information. So for example, some of them really were conceptual in nature, identifying you know, key constructs to understand so that we would understand the way performance reporting would make a difference. For others, they were just mentioning the type of programs they would put in place to try to do that and try to maximize the impact of performance reporting. And if papers or key reports would capture one of those two criteria, then we kept them in the analysis further in the work. So this was an iterative review process where we also embedded our own experience around that field. For some of the work that we found, we had participated in previous frameworks as well. So it was very difficult to do that kind of review from a totally independent perspective, and we had to accept this. And I've been also very transparent in the paper about the fact that this experience had to come in the process, in this iterative process, where we generated consensus and debated when there was disagreement about how to classify the work that we found. And then what we did to ensure that we were on the right track was to look at the framework we had developed and map it to the original studies to assess really the integrity of our work and the comprehensiveness of our work, and see if we were really helping to bring the field of thinking a bit further compared to all of the seminal papers and important reports that we could build on as part of this work. So Kim is going to talk about a bit of the foundations.
Excellent. Thank you, John-Fred. Yes, when we started looking at different levers and trying to look at what's being used in different contexts around the world and in different health reporting agencies, we saw that we could see that there was a range of academic kind of disciplines that have informed the levers that have been used and studied. So some key areas that where we knew that the literature was really influencing how we thought about levers for change. Firstly, institutional theory, the old iron cage revisited, where we're looking at whether there's mimetic levers, levers that really, from external forces, really influencing the way that people were behaving and making behaviour more consistent across different players at an organisational level. Another key theoretical background was the diffusion of innovation, the seminal work by Rogers, updated in a healthcare context by Greenhalgh and colleague in Milbank Quarterly, really told us a lot about the different players in securing change and how we really need to be cognizant of change over time and the different ways that interactions between what it is you're seeking to change, the actors, the context in which that change occurs. These really started to tell us of a different set of levers that we need to think about in putting into our model. We're also looking at kind of more psychological theories. We're looking at theories of behaviour change at an individual level. What motivates individual people to change their behaviour? Looking at work from Susan Mickey, done a lot of work in the UK in particular. Obviously, sociological theory also impacted and really can inform us when we're thinking about what different levers for change there are. And here we're really drawing out intrinsic and extrinsic motivations, thinking about where it is where individuals are making decisions and how they are influenced by their social context and social constructions. Finally, and really key, we're very interested in organisational change literature, very active literature in the last 25 years, thinking about planned and emergent change, and really in different types of organisations, what sort of levers have been applied in order to secure changes and improvements going forward. From a different perspective, we're also, so that's very much a theoretical perspective, we're also more interested in the way, can we describe the particular levers and how they have been used in order to, in practice, around, particularly in a healthcare setting. So for example, IHI, the Institute for Healthcare Improvement in the US, Don Berwick's work in quality improvement, work done that when I was in the UK, I worked at quite a lot with Sheila Leatherman, where we were looking at quality and improvement, and that work was done in conjunction with partners in the OECD when we were trying to understand levers for change across different healthcare systems. There's also very interested in safety and system change here, the practice foundations. We're looking at publications such as Crossing the Quality Chasm, the safety publications coming out of the Institute of Medicine, and really key pieces of work. Again, this was mostly based in the OECD, done with Peter Smith, Sheila Leatherman and colleagues, where there was really detailed information about different levers and how they have been applied in a healthcare setting. And finally, it was important for us to really recognise that we're talking about complex systems, and it seems that the most sophisticated literature or applications of the levers were done in full awareness that health is a complex system and that we need to be aware of the difficulties in securing change. And then finally, in terms of practice, we knew that there had been a lot of work done in pay for performance, for example, and a lot of work in the UK in terms of incentives and governance and how that's been used to secure change. And I'll hand back.
So now about the model. So you could see from the previous section the diversity of the different work. A lot of people had looked at that question from different angles, different perspectives. And looking at it, we could see quite a lot of similarities in different work, but because of their respective perspective and the specialization of their assessment, basically they were not all covering exactly the same thing. And that's why this integrated model came about. So the model really starts from that important distinction between the dimensions of emergent versus planned change and internal versus external motivation. So this is really combining, when you think about it, a system dimension with a more individualized, intrinsic energy, let's put it this way, together. So when we combine together those two dimensions, we can see it creates 4 quadrants where we could position different levers that were present in many of the literature that we surveyed. So the first 2 levers are in the emergent and internal quadrant. So we're really talking about levers that come from within when we think about the stakeholders and the different actors in the system, and also change that somehow will happen without a purposeful program describing what needs to be done. And the first lever is the cognitive one. And it's really the lever which is the most prevalent. It's very difficult to implement any change if there's not at some point a certain form of cognition, a new knowledge being created. And that really describes, all of the efforts done in developing new measures, indicators related to specific policies or programs. And all of those measures really give a new information to people to be able, so that they're able to reflect on where they stand, on how they provide care, for example. And it's probably the most accepted lever as well, but the literature was quite clear that it's also just a starting point. In many fields, we know that knowing about a certain situation, about your behavior, or about a specific determinant of health, for example, is not enough to necessarily make you change. And it's the same at the clinical level or at the level of systems. And so there's a second lever that appears when suddenly the information that is created through performance measurement or quality or safety measurement becomes publicly available. And it's the mimetic lever. So obviously this one is really informed by the institutionalization theory. It was one of the key 3 levers as part of this theory. And it's really one that has been drawn in more recent frameworks as well. And basically what it says is that we all want to be like people we like. We all want to be part of the group of high-performing people. It's all part of the gregarious desire of people. And therefore, clinicians, if they receive information about their performance and they know about the performance of a group that they really respect, then they will want to emulate that and try to be the same. We want to imitate people that we can see as leaders, as champions in our respective professions. So that's really a lever that requires already a certain form of transparency, so that we can really learn from others as well, in addition to learn from our own position. So if we move to the top left quadrant, which is planned in terms of how the change would happen, but still really working mostly on internal motivation, we've got two other levers. So the first one I'll talk about is the supportive lever. That's really the one that includes all of the tools, all of the facilitation that we can provide as part of quality improvement programs or organizational change management programs, where we actually plan what needs to be happening, okay? And then we put in place resources that we know will help people on the ground to change, but we still rely on them changing as the foundation of the transformation in healthcare systems. So, for example, we can bring together a group of clinicians, provide a facilitation with a few tools to understand a situation so that they design a new way to organize care for their patients. Or we can work on co-design with a group of managers so that they start to flow differently, the different resources that they have at the local level. The second lever in this quadrant is a formative lever. And that's an important one because it's often in reforms a lever that is first overlooked and very often under-resourced. Formative lever really starts from the assumption that most of the time people work the way they do because of their current level of competency. And if you're really to make a significant change in healthcare system, somehow there has to be a formative component. There has to be a form of improvement in competencies that you want to happen so that people will be able to first implement the change, but also work in that new environment and that new way to work. So obviously there's lots of educational programs that are part of either basic training or continuous education that would be key as part of this. And it's really working on internal motivation because ultimately it gives people tools, internal tools, to be able to enact the change or ensure that they can work in this environment and make it sustainable. If we move to the right side of the bottom axis, we have the external motivation component, where there's again a planned and an emergent quadrant. And the top right one includes two of the levers that have been the most, or very often very often resorted to in many programs, and two levers that are obviously very important, but are again just two levers part of that more integrated framework. And the first one I'll talk about is the coercive one. So that's really the carrot and the sticks. So we can talk about incentives or disincentives. We can talk about laws, regulations. We can talk about direct funding. We can talk about all of those things that people in position of hierarchical authority would tend to use to try to implement change or influence people's behavior. So of course, lots of pay-for-performance programs in recent years, lots of programs where direct funding is important, and also we can see it emerge in Australia at the moment. Financial penalties related to certain types of outcomes would all be perceived as being coercive levers using performance information from a more external motivation way in terms of generating change. The second one in this quadrant is a normative lever, and that's the one that tends to be used by professional associations and colleges because they have certain requirements for their members if they are to be accredited as part of certain craft groups. Similarly, accreditation is very normative in nature and very often uses performance information. So the normative lever is really when there is a bit of a checklist, a bit of an assessment of how things are being provided according to what we know, not just what we know is good or the norm, but in a perspective when it's actually required to achieve a certain minimal level of competency or ensure that some form of treatments that are not acceptable anymore are not done. Two very important levers, very often resorted to, very external in nature and planned. Obviously you have to decide how you fund things and what are the current criteria to establish what's good professional practice before change happens. Then if we go to the bottom right quadrant, which is external and emergent, we have two levers that have been less explicitly described in many models, but were present in the literature, and really are, and you'll see it later, are part of the addition, really, of this integrated model. So the first one is the structural, and the structural can be physical as well as more social or cultural structures. Those are external elements that influence our behaviors. So sometimes it's the way the physical environment is, designed in hospitals. Sometimes it's how the social interactions are bound by norms and cultures. Sometimes it's about how people envision how care should be provided. And you can actually work on that, but that structural element will always make change emerge as people are working in those environments. So to give an example, performance information can actually reveal that the actual way the physical design of emergency departments influences how nurses and doctors work together. Similarly for the ward, where positioning of the nursing station is now recognized as having an influence on how people perform in their task, even without them understanding that their behaviors have changed. So for example, positioning the nursing station in the middle of a unit creates a lot more interaction, a lot more transparency and visibility of different behaviors, and has been shown to have influenced how healthcare system is delivered. In a similar way, we know, and we always consider the fact that if you don't change certain elements of the social structure into which people are working, if some behaviors are not accepted, although they would be good for patients, or if some behaviors are accepted and are not very good for the provision of safe care, then you need to work on those structural elements as well, but from a more symbolic or social perspective. Finally, the eighth lever as part of this model is the competitive lever. And that's one that's a bit more contextualized at times. So first, it can be about giving performance information to insurance companies, and then they decide to purchase services differently. And just by that fact of moving the market, other organizations can decide to, in a compensatory manner, change their performance, try to compete for that funding, and ultimately get it. But also, patients can have a role there. And if we give the performance information to patients, the flow of patients to different units or different hospitals, according to what they want to receive in terms of experience of care, in terms of specific types of services, or in terms of the outcomes that are important for them, may also put an external pressure on services to lift their game and try to be an attractor of those clienteles of patients. So it's really external in nature, but it creates an emergent change because, it's not every single patient that goes to a new hospital that sends the message to the hospital, you need to change. Nobody's telling those hospitals that they need to change. It's an indirect influence that will create that improvement of performance from a competitive perspective. So 8 levers that really synthesize most of the fuel or energy that would make people behave in different ways and can be influenced by performance information is what we contend this integrated framework provides. So we do think that this framework is an addition to the previous literature. It provides a comprehensive and coherent framework to something that really emerged from different theories and different perspectives. So this table is from the paper, and it shows the coverage of the different levers in seminal papers that we had reviewed to create the integrated framework, but also shows how these different levers were present or not across different studies. So for example, we can see that the cognitive lever was present in most of the studies. Similarly for coercive and normative and competitive. Most studies were somewhere mentioning those levers, but we can see that the structural was not so much present and covered in the previous literature. In a reversed way, we can see that some models were more comprehensive than others at touching some of those in certain ways, but not dividing it in the similar way. So for example, Nalen, Ian, and Handa somehow in their paper in the OECD seminal work of around the year 2000 had touched really in different ways on each of those levers in describing what was happening in the field of performance measurement and reporting and how it would promote change. And we can see that the Berwick model tends to really be more about the formative, the supportive, the structural, and the competitive levers. And to a great extent, you know, these models also emerge from different countries where the emphasis on certain levers will tend to be different as well. So it's no big surprise that there was a bit of variability in the comprehensiveness of the framework, but certainly we can see that none of the levers proposed in this integrated model were absolutely absent from the previous literature. And we were happy to see that really we were building on other models and trying to provide this more coherent approach.
Okay,
yeah.
so just to have a bit of a discussion about how these levers are actually applied in different contexts and how they work, because yes, we've got 8 levers and there's lots of different characteristics of the levers, but what we can see when we look at both our experience and the literature, that these levers can sometimes be in conflict or they can sometimes be in concert. And when they are worked in concert, when they're lining up, we can see they seem to be much more effective. And so when we're looking at whether a lever works or not, it's always also important that to understand that they usually don't work alone, and that we see much more successful change efforts when they are applied together. So they're powerful, but they need informed and often nuanced application. And that means that, so if we're setting levers up that are in conflict, that's when we see that we're running into difficulties into securing meaningful change. So we've got lots of levers, and we've got lots of, often lots of organisations that have their hands on different levers. And that sets up a very interesting dynamic, both in terms of coordinating approaches to what it is that you're seeking to change, but also, is it possible for one organisation to hold all of the relative levers and successfully apply that leverage in a way that really both secures change and a change that is sustained and isn't just a temporary change where, for example, a particular incentive is applied. And once the incentives comes off, does the behaviour change then drop away? So we did want to think about, particularly in a New South Wales context, and that's what I'm going to talk about this morning, is how different organisations in different systems can have their hands on different levers and how they can apply different ways of trying to secure change in healthcare systems. So just to take you through a few of the organisations, the pillar organisations in New South Wales, starting with BHI, where I'm Acting Chief Executive. Really, our role is to report publicly on the performance of the New South Wales healthcare system. So very much we're very concentrated in the bottom left-hand quadrant, where we're trying to provide information back to providers, to hospitals, to the system about how they're performing. So we're really in the cognitive lever, letting people know how they're performing relative to each other and the system, how it's performing relative to other healthcare systems. So really trying to secure change at different levels in the system. We're also very much interested in mimetic, pulling the mimetic lever. So we provide information about how hospitals are doing relative to their peers so that they can understand and contextualise their own performance once we've made them aware of that. And for individual clinicians to be aware of the outcomes of their work, of the processes, and how they are compared relative to their peers. We also have lit up there the competitive lever, which are, and in some systems, yes, particularly patient choice is used as a competitive lever, and the way that we're publishing information in the public domain could theoretically, for sure, help support patient choice. I think the extent to which patient choice is really driving change in the New South Wales context, we have limited information about that, but really it is an important way of using publicly reported information to secure change in a number of systems. Moving on to ACI, where John Fred's now Chief Executive, much more in the planned internally situated quadrant. We're providing supportive education, collaboratives, providing information that helps people really make those journeys in terms of changing their behaviour. Very formative kind of levers are pulled very often, where information is provided over a long term, so you're getting feedback as you're making your change. And as John Fred said earlier, for most of the levers where performance information is available, cognitive information is really important. So in ACI, for example, a lot of audit and feedback, a lot of information provided back to clinicians so they know where there are opportunities to improve going forward. Another important pillar in New South Wales is the Clinical Excellence Commission, very much a focus on safety. They do use supportive levers, for example. They engage a lot with clinicians and LHDs and hospitals, really trying to support change. They do make people aware of the safety incidents, in patterns of safety incidents, and really understanding how different providers, what their results are relative to other similar providers of care. They also have a bit of a normative lever in that they are providing really quite clear standards and are checking against those standards, particularly in terms of safety type of interventions, where they're trying to support change in a very normative, this is what we are expecting should be done. And finally, if we think about the Ministry of Health, the bureaucracy, very often, as John Fred said, very often bureaucracies or the ministries use coercive levers. They use policy mandates and very clear requirements where if you do not comply, there are serious consequences. Or increasingly, they're starting to use financial penalties, as we mentioned earlier, say, for example, in terms of readmissions or safety incidents where they're no longer paying for patient stays. There's certainly use of normative levers where they're really sending out policy directives of what they require. They put in place structural issues, for sure, in the bottom right-hand corner, where they're really either putting in power and hierarchical arrangements, structural arrangements, and again, of course, cognitive, as I say.
So you start to see that, really we found that levers rarely operate in isolation. It's very difficult to act on a single lever with a certain type of information, and very often a report or a process of audit and feedback will really leverage two types of energy to make people change. And we have to understand that, because sometimes they synergize, as already mentioned, but sometimes they're also in conflict. We also realize as part of this work that meaningful and sustained change will happen more if different levers work together. There's really no way around that. It's much more limited if you just work on a cognitive perspective, or if you just try to have a coercive approach. You won't be able to reach as many people, potentially, as many aspects of what needs to change, or sometimes you won't even have the right dosage to make things happen and change. But we also found that when levers are in conflict, then it's unlikely that the efforts are going to be successful at implementing change. The coercive can be in conflict with the supportive sometimes, especially if it's the same organization trying to be both of those roles in rolling out a certain program. In a similar way, it could be that, if you try to use the formative approach, but you're not really good at that because of the nature of the specialization of your organization, you're not going to be as effective, and you could make mistakes that will make those performance report or systems report in conflict in terms of levers. And finally, change may fail because of a mismatch between the levers and the actual purpose of the performance measurement initiative. And that's really important, because specific measures may actually be good to leverage one lever, but absolutely not at leveraging another one. And that's why we need to be careful in thinking that only 15 or 20 measures of performance, are what's required to drive a system, because in reality, sometimes those measures will absolutely not support a coercive model or a supportive model or a mimetic model in terms of leverage. So it's very important to understand the levers, not just because they're relaying our information creates change, but also because we need to fit the right measure for the right type of lever we want to work on to achieve change. So this study is not without limitations, but it does have strengths. So it really draws on academic theories and models, and we've been very thorough in that space. It integrates various streams of thinking, and really we feel that this is one of the key contributions of this work. It proposes a straightforward typology, and we've presented it quite a lot over the last months, and it seems to be easily understood by people that there are various ways to create change, and information can support it in different ways through different levers. It's, of course, as everything, potentially limited by a publication bias. There's not a lot of literature of that nature in science. People tend to apply models and try to empirically find, associations, etc. So maybe there are some key levers that we have missed because of the publication bias. And also, our work was a non-systematic, layered approach to the review of the literature. We feel that it's the best model to do that. But if we had more extensive literature, we could have done a more systematic review. It was really not possible given the material that we had. So in summary, before finishing, and this is from the paper really, I think what this paper suggests is that the impetus for change can be, based on fear or hope. It can be built on pressure to conform, or sometimes an imperative to distinguish yourself. It can really be because you adopt an attitude of support or challenge in trying to influence change. It can be tacit, unsaid, or it can be very codified. It can be really focused, or it can be pervasive in scope. And it's a complex field, and our objective was to try to bring a bit more of an integrated view to that. So we do feel that this paper provides a clear framework to support better planning and evaluation of efforts to measure and publicly report performance in the healthcare sector. And we do hope that you will find it useful in your future work, and we'll be happy to have some questions. Thank you very much.
Thank you, John, Frederick, and Kim. Thank you. There's a Q&A button at the bottom of the screen. If people have any questions, please type them in there. I've got a question from Tilly Payne, who was meant to be chairing the session. She says, healthcare organisations measure performance poorly, and how can we use this framework to influence the measurement at the front end, i.e. convincing health services to collect meaningful data?
Well, I think that the lever, the fact that we recognize the presence of different levers and the fact that information need to act on those really puts a lot of pressure back on the measurement science, really to ensure that we challenge some of the assumptions of the current indicators that are present. So, for example, if we want to have a mimetic approach, well, it needs to be transparent. It needs to be attributable to a unit, at a unit level that we feel will drive people to try to imitate the good performers. If we wanted to feed into a supportive program or a quality improvement program, then the measurement needs to be more disaggregated and related to specific things that people do. So we also need to measure what's happening at the organizational level to be able then to target quality improvement efforts based on the variation measures. So there's lots of ways I think that it is challenging the current data collection, and that could improve in the future the capacity of health services researchers like us to use that material, use that data and that richer set of data to have better measurement to align with some of the levers.
And partially it's about what the purpose of the measurement is. Why is the measurement being done at a local hospital level or a local organisational level? What is it that we're seeking to secure? Is it to get a minimum standard? Is it to exceed, to excel? And what kind of outcomes or process change you're seeking to secure? And then you can be more nuanced in the way that you're measuring performance and how you can monitor whether you're achieving that along the way, and whether you need to change the different sorts of levers that you're going to pull in order to secure that behaviour change.
Thank you. Are there any other questions? I was just wondering, how the research maybe has changed the approaches in your two organisations with the information that you are publishing?
Could you say that again? I didn't quite hear, sorry.
If our organizations have changed because of, yeah.
I was just wondering how the research and your involvement with the research has maybe affected the approaches that your organisations are taking to the work that you publish and the reporting that you do.
So certainly from BHI's perspective, we're thinking about, well, if we're providing this mimetic lever or cognitive lever, whose cognition, who is the key actor in this part of our performance that we're seeking to provide the information to, and then you tailor the information depending on who that actor is. So for example, if you're trying to secure change in stroke care, and we've got 30-day mortality information, you know, what kind of lever is that going to act as? And it's going to be cognitive and mimetic, so we need to make sure that we're providing that information in a way that people can see how their peers are doing, and they accept that that's a fair comparison, and it is a basis on which they will act. So we are thinking about the way we're providing the information, given what we would anticipate the sort of levers that would be used in order to secure change.
And from ACI's perspective, you know, ACI is an organization that needs to roll out, you know, find innovations in the system, but also at some point in time ensure that it gets implemented. And what the framework is helping us to do gradually or increasingly is to really realize that our supportive approach is absolutely key, of course, but we need to align it increasingly with the coercive levers that are in place. We need to find what's the right information that from a cognitive perspective will also support people's journey in the quality improvement process. And therefore aligning the work different organizations is really made evident by that, or the need to align the work between organizations is highlighted by the levers framework, but also that at times we are forgetting that maybe there's an information and a public information element to some of our quality improvement programs if we want them to really be effective, because it is highlighting the fact that information can be a lever even from a supportive perspective, and even from a coercive perspective or a normative perspective. So I think it's really broadened the scope of how we use information for our own purposes as well.
But I think that's really key, the way that the different organisations, particularly in this multi-organisational context that we have in New South Wales, it's really informing those conversations that we have with the ministry, with ACI and BHI and CEC, all of the acronyms. It's really important that we're kind of having this as part of the dialogue, and that it's kind of establishing a shared kind of understanding so that we can have meaningful conversations about this.
Mm-hmm. I've got a question here from Rich Gillett, who says, you talked about how no single organisation can use all levers to affect change. However, in Western Australia, we do not have equivalent organisations to ACI, BHI, to affect these different levers. We only have a WA Health. How can we effectively use as many of these levers as possible from the perspective of a single organisation?
Yeah, no, that's a very good question, and I think it would be relevant in many contexts, not just in Western Australia. In many places, it's all embedded in the ministry, but also in some places there's a single knowledge organization at arm's length of ministries to support all of the work. In New South Wales, it's built in different pillars, which really provides us with an opportunity for specialization, but also an opportunity for, at times, having two different leads for levers that could be in conflict. So I think that the framework is useful in places where those structures don't necessarily exist either, because it may support the reflection about how to be more agile at leveraging all of those different dimensions without falling in the trap of the obvious conflicts. So being cognizant of the fact that you have all of those levers in place, and then you know, making strategic decision about how you roll out programs so that you would really synergize the levers that you can synergize from an integrated organizational perspective, and maybe be a bit more careful if you realize that your current organizational arrangements are not really supporting the mixing of certain levers. But that's not to say that those organizations are not monolithic blocks made in reality of specific subunits that can have a bit more of a specialization and a different way to use performance information to leverage those different influences as well. So I think that there's still scope for different teams to develop a specialization, different relationships with different stakeholders, even from within, you know, bigger and more monolithic organizations.
And equally, there might also be other organisations outside of the health ministry, such as colleges and those sort of organisations that are also pulling levers, and we do need to be cognizant and aware of how they're sending information, sending signals and leveraging change.
Thank you. Thank you. Do we have any more questions from delegates? Looks like that might be it. Do the two of you have anything else you'd like to add?
Well, maybe just to thank you for the opportunity for presenting today. You know, it's a framework that's around making sure that data and information creates action and change, and we do believe that it's the same thing that should happen across our scientific publications. We don't do those for the sake of publishing papers. So it's a great opportunity to be able to link with many of the members of the association across Australia, and I would invite you to contact us if you feel that there could be a local application that you feel we could support. Would be more than happy to try to further the work so that really this framework supports change within Australia as well. And again, I think it's a great opportunity that you've given us today, and thank you for that.
Yep. Thank you very much.
Yeah, and as I